It was, and it will be continue to be a learning curve for us. So I was the one who insisted with Rajalakshmi and Sri Devi that we should have one session where we, not everybody is happy to give feedback in the form of tick boxes, but we really want to improve the quality of this, sessions in the subsequent batches. So we really want this to be an open session. And since you'll have been there in the past 7 weeks to hearing all the other topics, we want to basically clarify any issues, any doubts that you all have had, and two, give us suggestions on how we could improve for the other batches. And also, there were a couple of doctors who wanted to share their experiences about patients. And there are some other questions sent on the group, which we will address. But to begin with, I actually had prepared a PowerPoint on asthma and COPD because I thought that was a very theoretical topic that had happened and in the case too, but it's not necessary to do that. I'm happy to individually ask each one of you, the feedback that you all have, where we can improve, issues that you all have, looking after respiratory palliative care patients when you in the OPD, in the inpatient, or when you go to patients' homes. So before we start, I think there are people joining in. We can request the two doctors who were happy to share their experiences. Rajalakshmi, will you, 1 minute, I'm just trying to.
We had Dr. Vinuta Raman and Dr. Gajasaraj with patient
So
story.
any of them have, Dr. Vinuta Raman, can you start with what you wanted to discuss? Can you hear us, Dr. Yeah.
Yes, ma'am. Good evening, ma'am.
Yeah, can we see you also? Or your bandwidth is not good? Great. Yeah, it's so nice to see your face with a name.
Yeah. Hello, ma'am. Good evening.
Hi. Please call me Rajam. I'm sure we are same age. Or you might be even older. I might be much younger. So don't call me ma'am.
No. I just wanted to share about a few patients, like when we suspect they're suffering from respiratory disease. Actually, like we are dealing with palliative care for cancer patients mostly, and they are presenting with cough as a symptom. So invariably they are being given mucolytes, so that's which aggravates their symptoms sometimes. So I just wanted to present about one patient, like 55 years old, a male with diagnosed with CA, posterior cricoid and upper esophagus, locally advanced. He was diagnosed with squamous cell carcinoma of posterior cricoid and upper esophagus. Initially, almost 1.5 to 2 years ago, patient presented with burning sensation in the throat, unable to eat spicy food, gradually developed difficulty in swallowing. Now presenting with increased cough while sleeping and increased dysphagia and chest pain during cough. So this patient had a CT scan done, which was showing ill-defined heterogeneously enhancing mass lesion measuring 10/9 millimeter, noted arising from the lateral border of the left piriform sinus and mildly bulging into the ipsilateral sinus, causing perineoplastic lesion, and biopsy confirmed squamous cell carcinoma. So this patient already received radiotherapy as well as chemotherapy. When he presented to our center, so he was on analgesics, off and on, like tramadol, step 2 medications. So he was given pan or omeprazole, whichever was available with us. Along with that, morphine was initiated, 5 mg initial BD and then 8 hourly. Then syrup mucin gel was prescribed, and he got relief with that. And with other adjuvants, like for morphine, metoclopramide, ondansetron, and taking care of his constipation. So overall, his response was like his symptoms were relieved better than before, and he was not known asthmatic or COPD or any known case. Chest was comparatively clear. So what I was trying to emphasize, that patient may present with cough, and like invariably physicians or staff, most of them, they prescribe this mucolite syrup, or these things may aggravate symptoms. So cough, we have to define whether a symptom, with because of what reason patient is presenting with that particular symptom.
Correct. So this is a very important point, that when you have a symptom which is largely respiratory, like breathlessness, cough, hemoptysis, we need to, especially as palliative care physician, have a broad thinking that cough doesn't mean chest.
Yeah.
Cough means it could be from the upper respiratory, lower respiratory, ENT, GI, cardiac. So as a physician, when you enter the house of a patient and you see the cough, that's when you need to ask certain questions. And this is the reason why we wanted to have these sessions, to marry the palliative care physicians who are mainly looking at cancer along with respiratory medicine, for simple reasons. One is that both can coexist. Like a COPD patient can have lung cancer, or a breast cancer patient may be an asthmatic. So when you go to that patient's house, you should know how to treat everything, not say, I am a palliative care physician, I will only look at your cancer, I cannot look at your lung. Because that patient is not in a position to come to a hospital to treat her asthma. So you should have basics of asthma, and all these illnesses, treatment has progressed over the years multifold. So by the time you and me have passed out MBBS, things have changed dramatically in every field. And it's very hard to keep abreast with every field. So that's why some sessions like this, where you have a crash course on certain things, it'll at least, the antenna is, kind of triggered when you see that particular patient. So you're very correct in saying that cough doesn't mean equal to respiratory. You need to ask questions. So the simple set of questions that I ask is, obviously you all know, is what kind of cough, dry cough, wet cough, during the day, during lying down, throughout the day, what color of the sputum, any relationship with meals, any relationship with bent. So automatically these questions then say that it is not the chest. Any past history of chest, any pneumonia, any TB, if everything is no, then it has to be GI. And especially with a symptom of heartburn, dysphagia, it is all concentrating more on GI. So you need to direct your questions and treatment towards the GI. And that is why it's important, like you said, mucin gel help the cough.
Yeah.
So it's such simple things. And sometimes we realize that the treatment of an illness sometimes is worse than the illness. So we give things that patients become more miserable with. And unfortunately, as doctors, we are very poor in taking back feedback. Doctors actually get offended when the patients say ki ye dawai se kharab ho gaya mera. Patients also get scared to tell doctors. Doctors also get offended saying this cannot happen only. Because I think we somehow become so think with so much of blinkers on that we don't want to expand our thought that it might be something else. For example, even I used to be very shocked that when patients reported not feeling better with morphine, I said, it cannot happen. It has to happen, and then you actually explore the anxieties and the reservations that patients have when you prescribe the morphine. So they don't take it at all. They have it with them. They don't take it. And if you're going to force them, they might not take it at all. So really, we have to explore what are your beliefs, anxiety, little bit heed to what they're saying, because that story that patient says has got so much of information that's going to pick up your clue. And unless you listen, which very few doctors do, I think in palliative care, we are trained to listen. So we are much better listeners. But otherwise, a busy hospital consultant interrupts a patient in 1.8 seconds of patient opening his mouth.
Yes.
So we really need to change the course of our this thing. And the other thing is, in a respiratory, see, as it is, being in palliative care, I have been in palliative care only for 5 years. But even then, I've realized what an uphill struggle it is for patients with respiratory illnesses only to be referred to palliative care. chest physicians struggle to refer patients to palliative care. And similarly with GI, cirrhosis, similarly with CKDs, similarly with neurology, MND, Parkinson's, Duchenne's muscular, the referral comes so late because they feel they can constantly do things and palliative care is end of life. Patients and caregivers also do not perceive non-cancer conditions as life-limiting. Because we as doctors never tell them COPD is life-limiting. I'm not doing anything to reverse the COPD. I'm only controlling your symptoms. Very few respiratory physicians tell that to patients. And the two things that help COPD patients is hardly practiced. One is smoking cessation, one is pulmonary rehab, on which there's a talk, which is a last talk next week. So important, and it has seen that patients really can improve not just their quality of life, but also the quantity of life once you stop smoking and once you start and do pulmonary rehab. So these are the things which are not even medical. You see, so many important non-pharmacological interventions actually can help a patient, which unfortunately we doctors are not trained in at all. We are so much taught about writing prescriptions. So yes, it's very important to have an open mind and also listen to the patient and refer to, whatever the patient has belief in. Like I would always say, don't trash homeopathy, don't trash Ayurveda. We don't know about it, doesn't mean it's rubbish. It helps some people. Massages help people. It distracts people. It relieves tension. Meditation helps. So all this is not there in our allopathy books, but music helps. Pets help. Acupressure helps. Acupuncture helps. So you can try to do these various things to patients for relieving different symptoms that you all experience. So thank you very much for that, Vinuta. Appreciate that. And then we had another Dr. Rajalakshmi, just remind me the name. Is Rajalakshmi not there?
I think it is Dr. Gajas Raj.
Okay, Gajas Raj. Yeah, Sridevi, thank you. I'm not sure he's logged in.
Hello, can you hear me now?
Yeah, I can.
Yes, Raju.
Dr. Gajas Raj is not logged in?
He has logged in, but I think Dr. Gajasraj, can you unmute from your end and speak? I guess there is some problem with his audio. I can call him, ma'am.
Yeah, and Dr. Dheeraj, yeah, anything you want to say, share, Dr. Dheeraj? There's one question that, 1 minute. Issue that I would like experts to share their suggestion till Dr. Gajas Raj is contacted. Coping with increasing anxiety. I think this has come from 1 minute. Dr. Subbalakshmi. So that this is her question. Coping with increasing anxiety in patients with progressive irreversible lung disease, both for the patient and caregivers, what role and when will anxiety alleviating drugs help? So, the honest thing is the first reason for anxiety in patients with advanced lung diseases is the fact that patients are not told the complete truth. Patients feel, even today, after seeing pulmonologists for 2 to 3 years of treating with COPD or ILD, they always say, I am being treated for ILD and I hope to be cured. And COPD patients also say, I hope to be cured because I am taking these treatments. So the first thing is the lack of information. Doctors don't share the information. Patients don't understand their illness. They feel they're coming to the doctor every 3 months, every 6 months, they are going to be cured. So the first thing is the lack of information. Once you tell the patient the complete trajectory of the illness, the natural course of the illness, then they need time to process and analyze. And that's the time when you also suggest counseling, because they are actually dealing with an incurable progressive illness. And that can be like diagnosing any patient of having cancer or an advanced stage cancer, because there is no treatment for ILD and there is no treatment for COPD. You are only doing symptomatic treatment. So they need to be referred to counselors, because this caregiver is going to also go through that long journey along with this patient of prolonged period of high symptom burden. Because typically you diagnose a COPD at the age of 60 or 65, and that patient can live up to 80 or 85. And he's going to have a roller coaster ride of admissions, infections, respiratory failure, depression, anxiety, frustration, NIV, oxygen. So it's a long drawn process. So both the caregivers and the family needs and the patient needs hand-holding. They need support. There has to be counseling. There has to be dietary advice. So it has to be a multidisciplinary approach. And unless your pulmonologist in the hospitals you are working or attached to get the idea of the benefits of palliative care and integrating palliative care early, this is never going to happen, because almost always all your patients will reach so late that they're not even able to walk and talk, and it's too late for them to process the severity of the illness. Very often patient says, I had come to the doctor every day. I mean, every time he asked me to follow up, I was so regular with my medications. I took all the vaccines and still, why am I suffering? Why am I still breathless? The point is all the inhalers and all the medications are only directed to symptoms. They're not directed towards curing the illness, because COPD is an illness which is anatomical disruption of the lung. So please remember that information sharing is vital. Involving counselors, physiotherapy, smoking cessation, all this is very important. And also understanding the needs of the patient, because all patients' EQ and IQ are not the same. So you feel, as respiratory physicians, we feel we have given all the information, but it's not necessary that the patient is understood. And busy hospital consultants like the pulmonologists don't have the time to handhold. That's why all the more necessary that you need a respiratory nurse or a palliative care nurse who will help these patients understand. And you know how it is with patients. All of you have experience with patients. You tell them the same thing again and again and again, and maybe they understand only the 10th time that this, and probably some even don't understand at that time. So I think that's the way to go ahead. It has to be a multidisciplinary team, and palliative care has to be integrated as early. And now my colleagues are seeing the benefit of having palliative care, and they say that a lot of their stress and lot of their time has got offloaded because there's somebody else who comes and tells the patients and the family what they can expect, how we can match their expectation, how they will be supported, and how the symptoms will be taken care. So typically what happens in my practice is, because I'm a pulmonologist, a lot of the neurologists and a lot of the respiratory physicians refer their patients to me. It takes a time and a while to build up the rapport. These patients are still coming to OPD, and that's where we assess their needs, speak to the family, write down the concerns, involve a family GP, involve the counselor or a physiotherapist, and then keep in touch every 3 to 6 months. And by the time we decide the goals of care, then very clearly the goals of care are written, explained to the patient and to the family physician. Now what I get is a message from the family that the patient is critical, that the GP has come to look after the patient. All comfort care is done at home, and then I get a message that the patient has passed away at home. If the patient's wish is to die at home. If the patient wants to come to hospital, then we see to it that the patient is in hospital. Negative consent for ICU and invasive ventilator. Keep the patient in the ward, surround the patient with loved ones, do comfort treatment, either it's high flow oxygen, NIV, or palliative sedation, and let the patient transition in peace. But all this takes time. It will not happen overnight, and it cannot, nobody can trust a stranger. So early reference really does make a difference. I don't know if I've shared this referral. I mean, we did a fam care survey of about 68 patients, which we had treated together, the pulmonologist at the hospital I work and me together, and we had sent out the modified fam care questionnaire to all the caregivers as to how well they were supported and how they felt during the process of end of life. And it was beautiful to see that most of my patients, about 68% of my patients died at home. About 72% of my patients were on morphine and comfortable. And the referral time was 8.5 months. So I had almost 9 months to deal with these patients on a regular basis. So it takes time to form trust and faith and the belief that yes, my patient can die peacefully without aggressive interventions and without the family feeling, oh gosh, how did I not take him to ICU? How did I not put him on the ventilator? So there, it is going to take time. And like Dr. Rajgopal, the chairman of Palim India says, people will first ignore you, then laugh at you, then fight with you, and then only accept palliative care. So it's going to take time. I think like another 10, 15 years, we can expect the consultants to slowly convert, because till date, hospital consultants think palliative care is giving up. Palliative care is only for advanced cancers, and palliative care is really at end of life. So we all have to work together to change this whole understanding, and especially with respiratory consultants, because if you see corporate hospitals, they lose revenue when they don't admit patients to the ICU. So I was clearly told on my face when I started palliative care, will you be able to generate revenue? So I said, turned around and told the medical director, I might not be able to generate revenue, but I might be able to generate goodwill. Because this patient's family is going to go out and say that this hospital cares about the patient and actually concerned about the well-being of the caregivers. And honestly speaking, if you think of any corporate hospital, an ICU bed, the more the turnover, the more the revenue, like I said last time also, because all your investigations are in the first week of admission. Then if the patient remains for a month, like we have dementia patients, we have patients with congestive cardiac failure, 90-year-old, so many, the investigations and the amount of revenue generated plateaus off even in the ICU. So you really need to, even revenue generation wise, putting a patient in the ICU for 1 month and 6 weeks is completely waste of time and so much suffering for the patient and the caregivers, that the word of mouth will be, this hospital लूटता है, ICU में रखता है, पता भी नहीं चलता है क्या कर रहे हैं ICU में. Because nobody tells patients and relatives, relatives what's happening. So there is the whole concept is different. And I think like it's very important therefore to integrate this and train our doctors to think differently. There is so much suffering. Like today, when I tell patients of stroke not to put a Ryle's tube, they all look at me and say, how can you feed the patient? But whether the patient wants to be fed, is the patient hungry? Has the patient expressed a desire of what he or she wants? Nobody sits and asks them, because nobody realizes or thinks that tomorrow it's going to be our turn. We are going to be on that bed. So there's no escaping it. So I think a lot of it is asking patients and caregivers what their concerns are. Where is our other doctor who wanted to ask the question? Because I can go on and then I'm going to go through my slides also in case any of the sessions, did you all have any doubts, any more clarifications on lung function or blood gas or issues when you go to patients home with respiratory problems, about oxygen, about NIV? I can try and solve your questions, but we don't seem to have Gajasraj. Do we have?
I think Dr. Vinuta has a question.
Yes.
No. I just wanted to comment about my experience. Like basically I'm an anesthesiologist, and I worked in ICU as well as in OT. So in ICU, I've seen patients whom we know that maybe they will not come out of the ventilator. We have intubated so many times, and elderly patients with all the like comorbidities with COPD and all, and multiple time extubation trials given, failed, and again reintubated, and all those things. And I used to feel sometimes in ICU, I used to say, please don't resuscitate to staff. So, but I used to have that sort of feeling that maybe I'm not doing, whether I'm doing correct or wrong, because I was not sure what would be done till I encountered with palliative care. And since I joined, I really feel what my sixth sense at that time, I used to feel that no, it is enough. And even for my own father, I remember like I can never forget that what he went through, like almost 6 days. He was on ventilator and he was put on muscle relaxant. He was only diabetic he developed acute UTI and then followed by urosepsis, and he was put on ventilator. He was arrested. Then he was revived once in between also. But I was working in Kuwait, and I was like transitional. I was here for a few days, and then I asked them to stop muscle relaxant. Let's see whether he's hypoxic damage has been done already or not. But the response was not similar, like what now presently at least we can expect in corporate setup also, that people will listen and patients will not be put on muscle relaxant. And that is how I don't know, somehow I turn towards palliative care. So he was on ventilator. Even when they declared that day also, they were doing CPR. I went with my sister, and I told them, enough now, stop it. My sister she is non-medical. She was not aware why. She was asking me, why are you asking them to stop? But I can make out that there is nothing more to be done. And at that time, at least, they should not make the patient suffer more.
Yes.
So
it's very difficult. And like you said, you never forget how your dear one passes away. And this is the reason how I got into palliative care after reading Dr. Rajgopal's article, Don't Torture the Dying.
Yeah,
it was it was a Times of India article on June 20th, 2016. I will never forget it. And that September, I was in Trivandrum to train. And this happens repeatedly.
Yes.
Every ICU. And it's a shame because, we are really treating that human being as just some, guinea pig or a ragged animal with no voice.
I don't want to blame the doctors also. Like maybe I might have done also during my younger days, similar thing. When patients are standing in front of us, we don't know what to do. We consider like death is like failure. That is what they say in conventional medicine. So we have to do something. That is what
so exactly, Vinuta, we need to change the system of training, especially because nobody budgets suffering. Nobody budget. Everybody thinks I'm going to cure. But in the process of that, nobody lets go. In the sense, like, for example, recently I saw a 58-year-old man who was looking after and was the only caregiver for his 88-year-old mother with dementia. Mother has a Ryle's tube. She keeps pulling the Ryle's tube. He keeps putting it back.
And because that is what being told to him.
And he clearly says, when I tried to, I asked him about what if, your mother has an acute illness or a sepsis, will you take her to hospital? Will you go to ICU? ICU, I will not do. I will not intubate. And that's when I tried to reason with him. Don't you think ICU and invasive ventilator is one end of the spectrum? Ryle's tube is the other end.
Another end.
It is the same thing. Whether you are doing this or that, it is invasive, it is obtrusive, you're shoving something into her and she's pulling it out. She's probably even in her demented state, telling you that she doesn't need it. So it's going to take a while for people to understand, for people to have conversations. My whole point is that your 88-year-old mother or 90-year-old father has not become 88 and 90 overnight, right? So we all need to start having these conversations with our parents saying, how would you like to be treated in an emergency? It is not an earth-shattering question, or it is not something that needs to be emotional and crying and all of that. But even if it is, it's better asked than not at all. And unfortunately, we don't ask only. And then we say, like this man said, I didn't ask my mother, so now I am the sole care decision. I'm the final decision maker. I will never remove the tube. So it is sad. And this happens repeatedly about unnecessary CPRs, unnecessary prolongation of life, stage 4 cancers on the venti in the ICU. It's happening repeatedly. Somewhere we have to train our doctors and make them more compassionate and kind and change this. So interestingly, tomorrow I'm actually going to Udaipur for the National Chest Conference. And I have been invited for a debate for palliative care in ICU versus aggressive treatment in ICU. So I'm not sure the full crowd is going to be chest physicians, and I'm sure more than 50% of them will not align with me. It's going to be a tough debate, but I'm very happy that at least I've got a chance to put my opinions.
But madam, invariably, most of the doctors, I feel they themselves know what they are doing is not correct. It is just them to make them realize that this is the way we should go.
But problem now, Vinuta, is they know that it is not right. They don't know how to make it right.
Yeah.
See, for example, not to intubate is one thing. But what do you do when the patient is breathless and jumping up and down? That is something nobody wants to prescribe the morphine and the
Morphine,
medicine.
yeah, that is the issue.
So people, it's very easy to say, don't do 1, 2, 3, 4. What to do, you tell me, na? When the patient is so breathless, the relatives are going to be jumping. Patient is jumping. You need to offer some comfort. When the patient is retching and vomiting, you can't say, don't do this, don't do that. You have to do something to stop that. So this is the point. I'm sure doctors, when it comes to their own, will not want all this done.
Yeah, nobody will want. Yeah.
Correct.
I have already written DNR for myself. I mean, will also. I mean, each doctor should think about these things. When we are dealing with day and night, we are dealing with death.
Which is what I always feel, that a profession closest to death and dying and maximally aligned to suffering is the one who shuns talking both. We don't want to talk about it only. So it is sad, but we really need to accept, and as we need to start making the difference from our profession. Yes. If we only are not comfortable talking about death and dying, imagine the community. There nobody is going to be. So anyway, good. Thank you. Thank you for the discussion. Anybody else wants to share something? Any suggestions on improving the course? Any topics to be included? Please let us know, because yes, Amar Pawar, of course you can share. Please unmute. Dr. Amar Pawar.
Yeah. Good evening, ma'am. Actually, I am from Mumbai, and right now I am in Trivandrum for training.
Oh, nice.
And my
you are
purpose.
In tips?
What, ma'am?
You are in tips?
Yes, ma'am.
Okay.
And my area of focus is to work for TB, and for a decade I am working for TB, and I was previously working as a chief medical officer in Shivdi TB hospital.
Okay, I've spent 2 months there.
Okay, I spent 8 years over there. So I just wanted to ask something, because here are many pulmonologists, and what I experienced regarding the TB, mostly I am focusing about the TB. Mumbai is capital for the tuberculosis. MDR, XDR, TDR cases are at higher level. Other than of Mumbai, majority of the people don't see even MDR, XDR, or they don't know even. So I have huge experience about the XDR, TDR cases. And what I see, since 10 years or 12 years, they are taking antibiotics due to the resistance. And government platform is nothing but what? We have to give at least 5 to 6 antibiotics. Even though it is resistance, patient have to take it. Even though they are suffering, they have to take it. I just want to ask regarding the autonomy, ethics, and patients' willingness for taking antibiotics. And the most thing is stigma. For a cancer patient, 10 people will stand beside the bed. But for tuberculosis, no one, single caregiver will be there beside the bed. Means that patient is not getting bed at hospital also, and not at his home also. He is not getting any kind of touch. He is not getting any kind of lovely words. He is not getting any kind of sympathy or empathy. So I am just decided to fight against this. I don't know how. With that dream, I came here. Actually, I am working as a palliative physician since 8 years, but I was not knowing. Because in tuberculosis, much of the work is regarding the palliative care only. And I don't know, can we count this as a terminal ill disease or not? Because we say at one point TB is a curable, but there is a resistance type of patients who are taking antibiotics after death also. Below the bed, there are huge number of medicines. and we are keeping forcing that you have to eat. We blame always that you have not taken antibiotics, so that this condition is there today. For 2 years they are taking antibiotics, or for years they are taking antibiotics. They are suffering, but no one notice, I think.
So thank you, Amar, for bringing this. And just to let you know, on in the 3rd week of November, there is going to be a team of doctors meeting to form a guideline for palliative care in tuberculosis. So fingers crossed, there will be some guidelines which is going to come. Second thing, yes, you are right. We need to take TB seriously in this country, because even today we lose one person per minute of tuberculosis in the age group of 15 to 49. So productive age group patients are dying of tuberculosis, and TB, which we are, like Amar said, multi-drug resistant, XDR, TDR, to a large extent is physician made. We are responsible for that to a large extent. Yes, of course, patients who have not been compliant also contribute to the development of resistant tuberculosis, but largely it is the doctor's ego, the fact that patients shop around and doctors, without any scientific logic, keep changing antibiotics. And what I feel really bad about is the communication. Today, if you diagnose a patient to have drug-sensitive tuberculosis, you not just write AKT, which is HREZ, isoniazid rifampicin, ethambutol, pyrazinamide. Then there's MVBC, pyridoxine, this, that, and the other. Patients don't know which is AKT and which is multivitamin. No doctor in the chest physician has the time to say, these are the AKT, these are the multivitamin. This you need to take, even if you take alternate days, okay, but this you have to take every day. And also explain the side effects. If any of you have taken AKT in the past, these drugs are horrible with side effects: gastritis, red urine, nausea, bloated feeling. Unless you tell, I know when I had to take rifampicin for that prophylaxis when I was exposed to meningococcal infection, it is horrible when you sit in the pot to see that red urine. If you do not take the time to explain to your patients that this all will happen, they will discontinue it. So a lot of the burden of TB today is physician made because of lack of communication, poor prescription practices, not conforming with WHO rules, keep changing drugs, and obviously the patient is going to be resistant to everything. It's like adding a rotten mango to a pile of good mangoes. Everything is going to get rotten. So appreciate your point, Amar, and really feel for you, but I will keep in touch with you once that meeting gets over. Yes, TB needs attention of palliative care. Drug-sensitive TB is curable. The rest all need hand-holding. But even the drug-sensitive TBs need palliative care because it is 6 months. No infection is treated for such a long time. Pneumonia is 2 weeks. Meningitis is 3 weeks. Empyema is 6 weeks. 6 months is a long time. Honestly, tell me, amongst this whole group of doctors here, how many of you have taken amoxicillin tablets 3 times a day for 5 days regularly without missing a single dose? If you and me can be non-compliant, imagine the uneducated patients. So you have to motivate them. You have to encourage them, educate them, which is all palliative care. Exactly what Amar said. And now he's just getting his skills polished in Trivandrum. But otherwise, he was always doing that. Yes, so we are going to come up with the TB guidelines for palliative care. So
yes, ma'am. Hoping
they
that
heard you.
Yeah, in the Mumbai, I'm hoping that my clinic will be the first palliative care clinic for tuberculosis.
And I will send you the patients.
Thank you, ma'am. Because all the patients are poor, madam. They are not
Yeah.
affordable. And, I do the things, many things, but the name specific palliative care for tuberculosis is important.
Yes.
It
Also,
have
you
to
are
highlight.
very correct about TB stigma and HIV stigma. Cancer is an emotional diagnosis. As soon as somebody is diagnosed with cancer, oh God, how can we do this? What can we do? Let's support him. Like, you will never see patients, you will never see many institutions which will say, let's donate for MDR TB. But for cancer, there is so much money coming.
Yes, yes.
We need people to have philanthropy towards MDR because those drugs are very, very expensive.
Yes.
So
And before the COVID, we used to use mask only for TB.
true,
Mask
true,
was an identification for TB only,
true,
was not even for pneumonia.
correct.
And
And unfortunately, TB is an endogenous reactivation. Yes, of course, immunosuppressed patients can get because of droplet, but the problem is basic things, na? Spitting, all these things also we are contribute to it. But you're right, TB only in severe TB we wore masks.
yes,
In the
and
normal hospitals we never wore.
and the second thing, ma'am, in Mumbai, the city Mumbai, where 10 by 10 room is there and 5 people are living.
Yeah.
There is no any kind of ventilation in the.
Patient. Yeah, correct.
How can one live with the mask, with the hatred in the family also?
Yeah. Somehow, unfortunately, TB doesn't get the sympathy that other infectious diseases do.
I think TB patient is not getting justice.
TB, leprosy,
Yeah,
and HIV. These are the ones they think कि आपने ही कुछ गलती किया है that you have got it.
yeah, the blame. Patient have to die with the blame.
Yeah. No, it's a good point, and I hope by the end, we get somewhere through those guidelines, because yes, TB needs palliative care.
Yeah, with the help of Dr. Rajgopal, I can do something, I think.
Totally. He's the man.
Yeah. Thank you.
Thank you, Amar, for sharing.
Yeah.
Rajlakshmi, where is our young Dr. Gajasraj?
Not actually able to. Hello, I'm not able to reach him. Dr. Gajasraj, he's still in the meeting, but
Okay, you were not able to get through to him.
yes.
Okay, fine. So any
Rajam, I think the study you were mentioning, your study, has
yes.
it been published already?
No,
I
no.
think it's going to be a landmark study for
I hope
referral.
so. So, Sridevi, actually, even Miriam, Professor Johnson told me to publish it. It was quite a heartening this thing, especially there was a section on comments and the things that the caregivers said, about, both Dr. Sujit Rajan and me, about the team, about whom we sent home. It was very heartwarming, and we didn't realize that we had made such a big difference to people's lives. So yes, Sridevi, I need a little bit of nudging and pushing to publish, but I will at some point. I am also can be lazy in some departments, but I will someday get to it. It's something that I did with Sunita. She had sent me the modified FamCare questionnaire, and it was quite encouraging to get the responses. So I think it really did make a difference. And you're right, we should publish it so that there are more respiratory physicians who are going to be convinced. Anything about PFT, ABG? Again, I'm asking, do you want me to? So I'm going to put up a question. I'm going to put up a slide on one of my patients, which I recently had. 1 minute. Where is my? So I'm just going to put up the question. So this was a patient of mine who died last week in the ward. He was admitted in the ICU 3 weeks before that. And he was an interstitial lung disease, progressive fibrotic, had met me once in May of this year. And he was basically told about his illness and the fact that it is incurable, the fact that it is progressive, and what to expect. And this time when he came in October, the beginning of October, he came with breathlessness. And apparently at home, he kept saying, let me go. Don't take me to the hospital. But the son was traveling and the wife couldn't see him suffer, and the wife got him to the hospital and basically told the doctors, do everything. He was then diagnosed to have pulmonary embolism, and he recovered from that after the clot busters were given, and he was extubated. 2 days after extubation, he had a massive GI bleed and re-intubated. So this intubation went on for about 3 weeks when I was called. And so this is one of the things I want to discuss with you as to like how Vinuta suggested, once intubated, extubated, intubated again. How will you as a palliative care physician, now that you'll have done this course on respiratory medicine, how would you like to approach? And I will then share with you how I approached it. Anybody wants to share? Because it's very fresh in my memory. The patient has passed away just 3 days ago. Anybody? It's not easy dealing with pulmonologists, intensivists, and hospital administration. So now with your knowledge of ILD, with your knowledge that it is incurable, progressive, how will you all approach this patient and the caregivers and the relatives?
Ma'am, I think we should communicate directly with the family. I think communication is the key.
Yes.
And explaining them about the concept of quality of life.
Absolutely.
Because from what I understood, the concept of quality of life in an Indian scenario has to be made aware. मतलब सांस लेना ही जिंदा होना नहीं है. That is something people fail to understand. And even when we were drafting end of life policy for our NABH accredited hospital, we are hopefully planning to start our first DNB in palliative medicine in Punjab. So I had a tough time convincing the critical care unit head about DNR and all those things. He said, "Doctor साहब, ये सब कहने की बातें होती है. At the end of the life, if any patient's relative sues you, there is nobody who's going to help you." And given the number of litigations against doctors, he said it is always good to save ourselves first. Gone are those days when you could actually think and act in patient's best interest, keeping everything in mind. But anybody can see you. Any one relative who was not there, he can come and say, "Doctor साहब आपने क्यों नहीं किया?" When the Supreme Court guideline says all patients have to be given life-saving treatment.
No. Supreme Court doesn't say that. Supreme Court says very clearly, if it is not in the best interest of the patient, you are allowed to withhold and withdraw. But the point here, doctor, is communication. And most importantly, documentation and signature of the ones who are legally heir. So wife, adult children, sabka signatures. Then no, Chacha's son cannot come and sue you.
Yeah, that's true. But the end of life care guidelines from critical care society and all those articles, and there is no proper legal backing from Supreme Court of India. So there is this gray area where all critical care specialists, they want to keep a part of themselves safe. And I really had a difficult time with ICU critical care in charge, trying to defend my ground. But anyhow, we made a end of life care policy. So I think communication is the key.
Some hospitals also have comfort care forms, and it is in red color. So once you've had that discussion, you put that red color in the patient's file, then anybody can know that this patient has signed the comfort care form. So I can share you a basic outline of the comfort care form, where there is a consent from the patient when the patient is well, or from any of the relatives like the wife, adult children, all of them, saying we don't want aggressive treatment. We've understood the natural course of the illness in the language we understand, and we want 1, 2, 3 things done. We don't want 1, 2, 3, 4, 5 things done. So there's a comfort care form which is available in certain hospitals, and that's a good idea because on admission, so suppose a pulmonologist has seen a patient of COPD or ILD, like this patient. I have seen the patient. If we have signed the comfort care form and the patient comes with the comfort care, then there is no business that the casualty medical officer forces the patient to go to ICU. You understand? So these are the things we can
emphasize. Is this similar to advanced medical directive?
So one kind of advanced medical directive, yes, it's a living will, but this is not endorsed or no legal matter. It is just between the relationship between the pulmonologist, the palliative care physician, the patient, and the family.
So,
Advanced
are
care
there
directive.
any
Advanced care directive is,
legal
suppose
issues?
he even goes, has a collapse in the house or in the station, then those things will not be real. This is something that we have discussed and we don't want 1, 2, 3, 4, 5. Sorry, you were asking something.
So, because the critical care in charge unit was advising me, even in case of advanced medical directives and withholding of life, end of life, you have to get permission from the court. Inform the
Oh,
this.
that
That
is
is the
what.
right way to go.
No, no. So that is the, unfortunately, the Supreme Court has come up with a complicated way of getting the advanced care directive thing sorted. Okay. But in the human interest, if you do this, you tell me, how does it reach the court if one of the relatives reach the court? If you have explained to the relatives and documented to the relatives and taken the proper signature, been there and supported the family, which grieving relative is going to leave the funeral and run to the court? So
Very well said.
all the palliative care physicians then would be actually in lining up to go to jail, right? The point is communication. So if, do you know that even this the in the US, where there's high rate of doctors being taken to court, 92 to 95% of cases is because of poor communication or lack of it. It is not because of act of omission or act of commission. It is more because humko to bataya hi nahi gaya. Nobody told us what's happening. Suddenly they have said the patient is dead. So even when we talk of violence against doctors, I am not justifying violence against doctors at all, but it is the poor communication. You cannot send a junior doctor to break bad news. It is not at all done. And how can you expect a 25-year-old to talk to 10, 50-year-olds and say somebody has died? You have to get them, you have to make them sit in a room, you have to build up saying there is not good news, he came like this. There has to be some way to break it. Na? So it is not, like I keep saying, na, tali ek haath se nahi bajti hai. It is not always everybody else's fault. We are also contributing to the all-time low trust of doctors and this thing, because we also behave like that. I mean, I know of doctors who have told my friends father-in-law, अगर आपका patient को ventilator पे नहीं डालेंगे, आपका patient मर जाएगा. So which husband is going to say, मेरी बीवी को मरने दो? Nobody is going to say that. There's a way, there's a place, there is a time, and there is a method of breaking this news, right? You can't tell that man outside the ICU, ventilator पे डालना है, नहीं डालेंगे तो मर जाएगी. Which man is going to say मरने दो? And this was a lady who was 72, IHD, asthmatic, CKD with dialysis for 2 years with a big fat pneumonia. What is she going to survive? Her outcome is going to be poor, but outcome was poor. At the end, the bill was 12 lakhs. So even this, I think the another way to do this research, now, Dr. David, is to go back on hindsight. See the patients who died in one particular month. See the selection of patients into ICU. So literature says that 25% of patients who go to ICU should not be in ICU in the first place. So if you're going to put poor quality patients in the ICU, 90-year-old dementia, or if 80-year-old diabetic, hypertensive, ischemic heart disease with congestive cardiac, if you're going to select patients poorly, then you're obviously going to have these issues. So patient selection is one. Second is time trial. For example, you have a young patient who comes with subarachnoid hemorrhage. You and me know what is the outcome of subarachnoid hemorrhage. But when the patient comes 45-year-old unconscious, you don't know what it is, you intubate, you do everything, and then you find out it's subarachnoid. Then it is your moral duty to convince the family and relative that this is a gone case, this is a brain dead patient, we need to withdraw. And unfortunately, withdraw and withhold are medically, ethically, and legally the same. The act of withdrawing is not going to kill the patient. The subarachnoid anyway is so bad that the patient is going to die. The intent is comfort. Intent is interest of the patient. And do you know, Kerala is the only state where If the patient is not for organ donation, the doctor need not intubate the patient with a subarachnoid bleed. So subarachnoid bleed हो गया, organ देने वाले हो, I will intubate you. Organ नहीं देने वाले हो, Tata bye bye, see you. Am I right, Sridevi? So it's very important.
Yeah. So, but I don't know how many of them knows about it and practice that.
That is
That's
true,
another
but it is a
thing.
law which is very advanced according to me in this country. No other place we, because otherwise these subarachnoid hemorrhages are in the ICU forever. So we need this whole understanding, this discussion, debate. Nobody is saying that we are right, you are wrong. But we need to find out from the intensivists what their issues are. I think that is important. Yes, we do not talk to patients. Communication in the ICU is where there is time, people talk to relatives on the corridor. Nobody sits down and talks to relatives. And I know what it is to have a father or a mother in the ICU. It's a horrible feeling, even as a doctor. As a non-medico, it must be miserable. So what we did with this patient is that convinced the family. So only the son was reluctant. The son said, "Nay, I will do everything. I will do everything. I will do everything." After 3.5 weeks, when the patient was finally extubated, the patient said, "I want to go to the room. I don't want to be in the ICU." That's when we shifted the patient on a morphine midazolam infusion and oxygen to the ward. And he actually died within 3 hours of moving to the ward. But the point is, the 3.5 weeks he stayed in the ICU was only misery. 2 times intubation, so many blood gases, because once you're in the ICU, you're on the conveyor belt, na, constantly karte raho, karte raho, karte raho. So it's a lot. So, I mean, it's really sad that we go through this. And what I just wanted to share what we do. So basically, thankfully, I deal with a group of pulmonologists who refer patients. First, because of my knowledge in pulmonology, I'm able to understand a lot that the pulmonologist has been doing. We gather the patient's knowledge of the condition, explain to them. And most important is I involve the GP. Because if the patient has to remain home, you need a family physician. And the family physician needs to be trained in palliative care and your whole idea of anticipatory prescription, morphine for breathlessness, how to give the subacute morphine, all of that, because sometimes the patient can stop eating orally. And therefore, then the patient needs to have a alternate route, which is subcut morphine. We thankfully get morphine vials in Bombay, so it's easy to train these patients to give subcut morphine. How many of you use subcut morphine at home in your practices, if you all are doing home visits? Any raise of hands?
Can't see anyone.
Anybody? I mean, is it because of lack of availability of morphine vials? Then Pallium can help you get those sorted, I hope. Not at home. Gajasraj has finally put up a question, so we will answer that. Yes, Dr. Rajesh.
Of course, Dr. Rajesh. Yeah.
He will do, of course. Anybody else? She comes from a very evolved state of Kerala, the lucky ones. Nobody else. So even amongst palliative care physicians, Sridevi, there's a lot of reservation. Any reason why? Can you all share why you all don't use subcut morphine in the house? Availability, expertise, confidence, or this thing, some reservations from the family and caregivers? Not available
For the fear of misuse.
for the
Yes,
fear of
our
misuse.
state is
But
one of
even
the
oral morphine is fear of misuse, na, Dr. David? You come from the land of Udta Punjab. So there's an extra fear there. But even oral morphine can be misused. Lack of experience. Okay, availability, use it only in the hospital. So if you involve a GP, why will there be a lack of misuse? Think about it. It can really decrease your hospital admissions without any reason. It's different that if the patient is in hospital and then it all happens. But you have a chronic patient, respiratory patient, he's going to be breathless, he's going to deteriorate, he's a COPD, he's interstitial lung, then you should, at the time, especially at the end of life, prescribe morphine. Lack of availability could be, yes, I agree, Dr. Rajesh. And trained professional.
And maybe you are not giving in bulk. So, I mean, you are not giving a lot of medication, right? We give the diluted one in loaded syringes and we tell them to push 1 ml whenever needed. You are not giving the vials directly. We
Correct.
dilute it and give, right? Label it and tell. And we are not giving it like 4 or 5 syringes. We just give one syringe. We tell
They're
them to
supposed to
come back
report back.
and
So, Sridevi,
refill
I
it.
do
And
a little differently because I am very remotely connected to patients in the sense of geography. So what we do is tell the GP, first of all, we give the prescription of the morphine because the GP might not, his or prescription might not be honored. Second, we give one vial at a time, correct? We teach the GP how to dilute it and then we monitor the dosage. So every time they've given it, I get a message. So it's a little different from Kerala, but you're right. It's not that we give them prescription for 5 vials. The chemist only will call up and tell me, Madam, why are you asking for so much? Because usually when you're prescribing morphine in advanced respiratory diseases, it is really for transition at the end of life. That's the only, you don't need more than 1 vial. So they have said lack of experience, lack of GPs are scared. I appreciate that. That's why you need to involve the GPs much earlier in the life of a COPD or an ILD, saying in the end, this will, so you keep preparing the GP also that a situation will come where it is needed. And believe me, in Bombay, most of the patients who have sick patients at home can afford, or most of them do afford to have, or rather, let me check, corrected, private patients who can afford to have pulmonologists in private hospitals afford to keep a nurse at home. And therefore, you can use the services of a nurse along with the GP to administer the morphine. Injection morphine, they don't give for home use in Chennai. Okay. But Gajas Raj's case was 85-year-old patient, advanced CA esophagus, end of life at home with respiratory distress. What can we do? Morphine? Absolutely. Low dose, yes. And if cannot swallow, then subcut. And at home now, then you can use a patch. Maybe that's not, I don't say patch very easily, but then you can use a patch if you're not going to give injectable morphines at home. So I think anything else you want to add, Sridevi? Because I think you look after these patients way more
no,
than I
I
do.
think we
And
also
Dr.
give the
Rajesh.
same thing, low dose morphine. If not able to give orally, maybe subcut or rectally.
Rectally. Dr. Rajeshi, would you want to add on to that? Because it's completely your domain. Yes.
Dr. Rajam and Dr. Sridevi, while I was in Calicut, it was easy for me to get injectable morphine for use when we go for home care. So that happened because the custodian of injectable morphine as well as oral morphine was palliative care professionals. Though it was functioning in the medical college, Calicut Medical College, the custodian was palliative care professionals and the group. So it was easy for us to get access to both parenteral as well as oral morphine. It was not a problem at all. But from Calicut, when I moved to Malappuram, where the palliative care is extensively delivered through community projects, so they have access only towards oral morphine. So injection morphine was not available or not allotted for the particular units. So even, I mean, there were situations where I badly needed morphine, injectable morphine, while I was doing home visit, but unfortunately, sadly, these things were not available. And presently, I am working in Thrissur, where injectable morphine is available. For special purpose, we can take injectable morphine with the consent or with the approval of the head of the institution. That is not a problem. The patient really needs it, and it will be given by the trained nurse in the supervision of the doctor. But in Amrita Hospital, we don't have. I work for Amrita as well. In Amrita Hospital, recently a thing has happened that the custodian for morphine is not palliative care professionals. It is by a different unit. Okay. Now, previously injectable morphine where it was available for use in palliative medicine OPD, but that approval was just taken away. So it is available only in oncology ward, that too for emergency purpose. So if we want to give injection morphine to a patient coming to palliative medicine OPD, we have to give intent and procure it. So we can just we can imagine the turnaround time, how much time we will lose in the way of getting the medicine, and the patient will be writhing in pain. So that
But
is what happened.
one question is, why is it only to oncology?
And they think that oncology people can at any time they can have pain. So they have gracefully granted 1 vial or 2 vials only for oncology ward. But unfortunately, it has been taken away from the palliative medicine department. I don't know why. And previously it was there. We used to find it very, very helpful when patients coming with severe pain, our own nurses can initiate the morphine trial. Now it is not possible. We can definitely do, but we have to get it sanctioned. We have to break all the red tapes. It will take minutes. Not only minutes, probably sometimes 40 or 45 minutes. So it is very sad. And Dr. Shobha is fiercely fighting for morphine to be back in the department.
Imagine if Kerala is like this, and other states have no hope only.
And if I understand correctly, in General Hospital Ernakulam also, morphine is stored and dispensed by the oncologist, I believe, though there is a full-fledged palliative care unit in the General Hospital. That is the biggest and the oldest General Hospital, if I remember correctly, after government hospital, General Hospital in Trivandrum. So there recently, when I spoke to Dr. Geeta Vijayan, who is a palliative care physician there, she said morphine is dispensed through the oncology department. The palliative care people can write, definitely write, but they have to get it procured from the Department of Oncology. If I remember correctly, I don't know whether the policy has changed recently or not.
So overall, morphine procurement is difficult, and vials are even more difficult.
Yeah, and there is one bottleneck here. I think any trained professional can give his signature, a statutory signature for only 2 units. That's what I mean. He is the authority to provide his signature for procuring morphine only for 2 units. So in Malappuram itself, there are more than 100 units. There are not even like 50 people working there. And the government, the people working in the government sector, they are not allowed to give sanction for the NGO. So NGO, they have to find, literally they have to chase professionals who had training in palliative care. So I have left Malappuram in 2017. Still, I am the authority for 2 units there. So they regularly send the forms and they get my signature in the register. When I go to I go to Calicut, they just bring the register to get my signature in the book. And every year they send the formats, the different formats for renewal.
So there's a lot of work to be done. We talk of comfort, but if patients don't get it, then there is really no point. Yes, of course, we can do the hand holding, be empathetic, but we need the medication.
Yeah, we need the medication. You are absolutely right.
It's very disheartening. I don't know, see, because I work in a completely private setup, I send the relatives to the chemist who has the thing, he will give the medication. So I use those routes, but obviously the bulk of the India and bulk of Indians do suffer a lot. And imagine, even if you're rich, you're not going to get access to the medication.
Yeah, absolutely right. Absolutely. So that's why Dr. Rajagopal sir, every time he just advocates for policy change. Yes. And easy accessibility to morphine, and that is the cheapest and the most economical and most safe
and
medication.
efficient. Yeah, so
efficient.
So true. So, I mean, the most feedbacks from caregivers is how the transition was so comfortable, how they died in sleep, how it was comfortable for them to accept their death because they were not like jumping up and down. They were in their own house, in their own bed. So there is a lot of work to be done.
Definitely, ma'am. Definitely.
I think it's almost 8:10, so we can actually
Yeah.
really.
I just wanted to ask quickly, Rajam asked in between whether there is anything else that they wanted from these sessions
Sure,
where the
yeah.
expectations
Yeah,
were met, or
please send us.
any
If you
feedback we
don't
can
want to
work on
tell
it.
us upfront, please send us because we want to evolve this session. We have realized the misuse of inhalers, oxygen, NIV, and especially for patients like all of you who go to say look after lung cancer patients at home who have COPD, then you know what inhalers they're taking, how they're taking, whether to yank up the oxygen, when to use the NIV. These are the practical things which will actually comfort the patient. So I think it is very important. If you all have, understood, you all want anything more, any clarifications done, it's very important for you all to ask and share with us. And next week, I think we have a session on pulmonary rehab. So the two
Yes.
physiotherapists will be there who will be talking on pulmonary rehab and the importance of pulmonary rehab.
Ma'am, I had a question, ma'am.
Yes, yes.
So this patient of yours, which you had shared, who came with acute breathlessness, so in the first, he shouldn't have been intubated in the first place. For the first intubation also shouldn't be done. Then at that time also the acute breathlessness, you would have treated with morphine.
Yeah. See, the point intent is comfort, ma'am. So, to be honest with you, if you're not intubating the patient, then it is your duty and the patient's birthright to be comfortable. How will you keep the patient comfortable? With low dose morphine titrated to his need and keep the patient comfortable. If he's anxious, you can add midazolam. If he's agitated, you add haloperidol. Keep the patient comfortable because if the patient is comfortable, the relatives will be comfortable. And tell the relatives why you're giving what drug so that the communication is clear and what to expect. Because with morphine and midazolam, patient can go to sleep. They will say, why is the patient not talking? So you have to say that the patient is awake, then he's aware of his distressing symptoms. If in order to make the patient comfortable, you need to use certain medications which will make him more drowsy or more sedated, and that's the reason you're giving. So this is when you withhold intubation. When withholding intubation also, the intent has to be comfort of the patient.
But pulmonary embolism is a treatable cause, no, ma'am. So why should we?
No. So that I'm saying pulmonary embolism is treatable. What I'm saying is suppose, so I'm not saying, see, for example, you need to understand, Sheila. So if it's an isolated pulmonary embolism, you have to go all out, arm and leg to fight that. But if it's a patient with COPD, ILD, advanced cancer, diabetes, hypertension, multiple comorbidities, poor quality life with the PE, probably PE is the best way to go. So isolated PE, I'm not even talking about. But so many things, multiple hospitalizations, comorbidities, poor quality of life, bedridden patient, that patient, what are you going to achieve by treating his PE? His advanced cancer is still there. His COPD is still there. His ILD is still there. You have just prolonged his misery. Am I answering your question?
Yeah, I got it, ma'am. I was just wondering the same thing.
Isolated
Why?
PE, even if a 90-year-old comes with the isolated PE, you should do everything. If he has a good quality of life, lots to do, you should do. But if you have a it's like this, na? Always I say this, if you have an 80-year-old who comes first time sick, breathless, you have to go everything unless the patient has given you the consent not to do anything. Vis-a-vis an 80-year-old with dementia, with diabetes or some other comorbidities, you have to treat it differently. Now, you cannot treat all patients in the same way.
Got it, got it. Thank you, thank you.
So in our ICUs, we treat 18-year-olds and 80-year-olds in the same way. We don't think only. It's a casualty, ICU, intubation, central line, arterial line, dialysis. Nothing, nobody stops. And even if you put the patient on ventilator, there is something like a time-tested trial. You see 2 days, 3 days, 5 days, 7 days. Talk to the relatives how much they want to wait. After that also, there's no improvement. You really need to have some action plan because the patient is suffering and not going anywhere. And that's why modern medicine prolongs poor quality life. You need to use the modern medicine logics rationally in a manner where it improves the quality of life of the patient and the caregivers, and you address the health related suffering, anything curable, you should go outright to reverse it. Always the first mantra is correct the correctables. It is the one which is not correctable that we are talking about, that we need to give them respect and dignity and comfort.
Agreed, agreed. Thank you.
Absolutely
Anybody?
right. Absolutely right, Dr. Rajan. It is, I can't agree anymore. You know, if we start the conversation in the very beginning, and most of the family members are compliant and they are happy to get along with comfort care. That is what today also when I spoke to one of the children, I mean one son of a patient with COPD, and he's having hospital acute pneumonia and it is not responding to even very high antibiotics. And he was telling us, doctor, I can follow what you mean. Even I don't want to see my father struggling like this. So it is the importance of communication. We fail to communicate to the people. That is what I had understood. And also we have made protocols, but that is not at all contextualized or not at all individualized. The protocols must be there in the backdrop, but everything should be adapted to the individual and the situation. That is where we fail most of the time.
Correct.
And the family will be ready to accept if they are given enough time to,
Forewarned.
yeah, that is what to sync with the information and to discuss among the family members. I mean, they will find it very difficult if you just ask them to take the decision on the spot. They also should be given some time to grasp the information, sync with the information, and to finally come on a comfortable platform.
Correct. Also, ma'am, it is our onus. I always think our onus to foresee and foretell, because we know the trajectory of the illness. We have seen
Exactly.
100 COPD patients. We have seen 100 ILD patients. We have seen 100. So tomorrow, if you imagine you are in the situation where you are told this, it's not easy even for you as a doctor to comprehend
Absolutely.
your own
Absolutely.
loved one. And that is one of the reasons why, this Sheila brought out this good example. So I'll just share this anecdote. The reason I got into palliative care, I'm sure Sridevi already knows it, is in my dad in October 2015 suffered a stroke. And because he was 88, the neurophysician said that nothing can be done. I will be giving statin and aspirin. So I said, if you're giving statin and aspirin, I don't have to keep him in hospital. I will take him home. And we waited for 3 weeks. I explained to my mother, my sister, and everybody why we are doing that. Everybody was aligned. We did nothing. We just waited. His consciousness worsened. My mom insisted on putting on a Riles tube, which now I realize prolonged his life. And we waited and waited till he died. And after my father's 13th day, on the 14th day, my mother was having fever, but we thought it was grief and everything. On 14th day, her saturation fell. She's an asthmatic, so when she was coughing a lot, I checked her pulse ox. It fell to some 86. So I rushed her to the ICU. The first question that my mother asked me after she recovered is that you didn't take your father to the ICU, but 2 weeks later, you took me to the ICU. Why did you take me to the ICU? I could have also just died at home, right? But the point here is, I can treat a pneumonia. I can't treat a CVA, MCA bleed, which has got, it's impossible. So this is the whole funda, Dr. Sheila, that you have to try every attempt to reverse the reversibles. And touch wood, 7 years on, Amma is staying with me, independent. She has other health issues, but independent. And at 84, she's able to enjoy the joys of having a great grandchild. So all I'm trying to say is, even in that 15 days, the thought process was different. You have to fight tooth and nail. That's the duty of a doctor, to reverse all things that can be reversed and get the patient back to a decent quality of life. If you fight tooth and nail and patient continues to be a vegetable, then you really need to sit and think of prolonging a meaningless life. So that is what is important. And I think it's very important to integrate in all specialities. And I think that's the voice that comes from doctors like Dr. Raj Gopal, Pallium India, Dr. Rajeshri. We're trying to do this more and more, and we need people like you to join us so that there is a wind beneath our wings. Thank you so much, Dr. Rajeshri, Dr. Vinuta, Sheila, Amar, for sharing. And you please can take my email address. I think or we are on the WhatsApp. So if there's anything,
Yeah, you are there on the WhatsApp group anyway.
if there's anything in future about any particular patient, please share. We are more than happy to help. If you make a difference to one life, it is purpose solved.
Thank
Okay?
you so much,
Thank you
Rajam,
so
for
much.
spending a lot of time in answering all the questions and patients.
No, my pleasure. Anything to see the cause of palliative care move into the world of other specialities. More and more needs to be done.